Good afternoon, everyone. Welcome back to the IAS Educational Fund Symposium for Western Central Africa. My name is Dr. Cheme Atuahin. I'm the Director General of Ghana AIDS Commission. I'm a public health specialist with more than 25 years experience. I'm happy to be moderating the second session of the symposium, which will be focusing on innovations in HIV testing and diagnostics, the path forward to scaling up. You may recall that the UNAIDS reported in the Global AIDS Report for 2021 that at the end of 2020, more than 16% of HIV population was still undiagnosed. And when in sub-Saharan Africa, compared to Eastern and Southern Africa, you clearly can see that the majority of undiagnosed HIV population in sub-Saharan Africa is in the Western Central Africa sub-region. And therefore, it is very important for us to scale up HIV testing, especially to reach out to underserved populations. And fortunately, thanks to technology, we have self-testing, which is helping us to, increase uptake of HIV testing among underserved populations. We have a very interesting lineup of speakers this afternoon to help us discuss the topic. And we also have panelists for this session who will be commenting on this topic as well. And will participate, we'll have a Q&A session as well, in which you, the audience, will also have the opportunity to ask questions. We sincerely hope that this program will be of great value to your work, and we hope and look forward to your active participation. Before moving on to the presentation, I'm now going to share some housekeeping rules. Number one, all participants will have to keep their will have to mute their microphones. And in fact, they are all muted at the moment. Please note that interpretation in French is made available to those of you connected online. Please select your language at the bottom of your screen to hear the presentations and discussions in your preferred language. I invite all those connected virtually to please introduce yourselves by typing in the chat box that is right underneath the screen, and you will see that your message shows in the interactive box to the right of the screen. Please type your first name, last name, the organization you work for, and the country you are from. Let us use this opportunity to connect and get to know each other. If you are having technical issues and are unable to see the chat box, I would like to invite you to change internet browser and to select all cookies to be able to interact with the speakers when entering onto the platform. Please use the same chat box during the questions and answer time that will take place right after the presentation. You are also welcome to send comments in the chat box. As an active participant of the IAS Educational Fund West African Fund Western Central African Symposium, you have the opportunity to receive a special IAS membership offer. If you buy a 1-year membership, you get 6 months extra for free. And if you buy a 2-year membership, you also get 1 year extra for free. To take advantage of this offer, please send your request to the email address provided. I will now want to introduce our speakers. We have Dr. Joseph Lamaranche. Dr. Joseph Lamaranche is a senior demographer at IRD, which is a French research institution for sustainable development. Over the last 15 years, he has been working mainly in HIV in Western and Southern Africa, specifically on HIV testing and new prevention strategies in the general population or among key populations. He is currently the principal investigator of the ANRS 12381 Princess Study, which is implementing sexual health mobile clinics, which covers pre-exposure prophylaxis, that is PrEP, and hepatitis B virus management, targeting female sex workers in Côte d'Ivoire. He is also the scientific coordinator of the UNITAID-funded Atlas project, which aims at promoting and distributing HIV self-testing kits among key and vulnerable populations in Côte d'Ivoire, Mali, and Senegal. Dr. Lamaranche will present on lessons learned from self-testing during the pandemic, which is an Atlas project conclusions that will be shared with us. Dr. Lamaranche, you have the floor. Please, you have 10 minutes, and I believe you will stay within time. Thank you very much.
Good afternoon. My name is Joseph Lamaranche. I am a public health demographer at the French Research Institute for Sustainable Development, and I have been the scientific coordinator of research activities embedded within the Atlas project in Côte d'Ivoire, Mali, and Senegal. Today, I will have the pleasure to share with you some lessons learned from HIV self-testing during the pandemic of COVID-19 from the Atlas project. Mainly funded by UNITAID, the Atlas project was coordinated by Saltis NGO with the support of ERD and implemented in Côte d'Ivoire, Mali, and Senegal with the support of National Ministry of Health and more than 30 local partners. 1,400 dispensing agents were trained for HIV self-testing, and around 400,000 HIV self-test kits have been distributed since mid-2019 on more than 170 distribution sites. Atlas distribution strategy was relying both on primary distribution, where self-test kits are given directly to beneficiaries, and on secondary distribution, where self-test kits are given to people and then allowing them to redistribute HIV self-test kits to their partners and relatives and peers. 85% of Atlas strategy was targeting specifically key populations, in particular female sex workers, men who have sex with men, and people who use drugs. In Côte d'Ivoire, Mali, and Senegal, during March-May 2020, different measures were implemented by governments in response to the COVID-19 crisis. Groups gathering were banned from mid-March. State of health emergency was declared in the free country between 20 and 23 of March, and several measures were restricting population movements. In particular, curfew was implemented in Côte d'Ivoire between March and May, in Mali between March and May, and in Senegal between March and June. Since June 2020, we are much more in a stage of epidemic management with easing of the different measures. This graph presents the number of HIV self-test kits distributed through outreach activities targeting key populations per month and per country. In all three countries, the pre-COVID period saw a gradual increase in activities. During the initial emergency response to COVID-19, March-May 2020, presented in gray on that graph, the distribution evolution differed by country. In Senegal witnesses a total cessation of activities during these 3 months, irrespective of the distribution channel. Côte d'Ivoire saw a significant drop in the number of distributed HIV self-test kits, particularly in April 2020. Mali saw the stabilization of the number of distributed, cessation of the growth observed pre-COVID. From June 2020 onward, with the routine management of the COVID-19 pandemic, a catch-up phenomenon was observed. Activities resumed in Senegal and the number of distributed kits rebounded in Côte d'Ivoire and Mali. Independent of COVID-19, Atlas outreach activities were heterogeneous across the countries and the key populations, as several intervention models are used. On that graph, the number of kits distributed per month are presented according to the size of the population targeted by the interventions. Face-to-face activities are represented in yellow. In green, you have small groups, 2 to 4 persons. In blue, medium groups, 5 to 8 persons. In purple and brown, big groups from 8 to more persons. In Côte d'Ivoire, activities in big groups, represented in purple or brown, were suspended during April and May 2020. It was mainly social events. In June 2020 and later, to catch up on distribution activities, medium-sized groups were organized with in blue and purple and green. In Mali, as in Côte d'Ivoire, during the emergency phase, large group activities were reduced and face-to-face activities were prioritized. And as in Côte d'Ivoire, you can see a catch-up phenomenon in June and onward. In Senegal, all activities were suspended between March and May, and upon resumption in June 2020, some activities were conducted in larger groups to catch up. The measures taken by governments and the application of hygiene measures led to major changes in HIV self-test outreach activities between March and May 2020. In Côte d'Ivoire, peer educators made several adjustments for activities targeting female sex workers and men who have sex with men. Relocation from public, bars, venues, brothels, to private areas, home, discrete places, etc. Group size reduction with prioritization of face-to-face talks when possible. Peer educators reported similar adjustments in Mali, with variations by region depending on how closely local populations have followed governmental health measures. Also, we have observed an increased use of social networks, Facebook and WhatsApp, the integration of COVID-19 hygiene measures, and some new site openings have been postponed after the crisis. A peer educator working with people who use drugs in Côte d'Ivoire told us, "We divided up, we took them in small groups." Another peer educator working with MSM in Côte d'Ivoire, "In the COVID-19 period, since we couldn't really meet, I did everything online, that's it. I was raising awareness online. When it comes to dispensing self-tests now, I move around, we meet up and then I give." A female sex worker's peer educators in Senegal told us, "Before COVID-19, we used to go out at night to distribute to bars and restaurants. But with the pandemic, we were obliged to change our strategy and give priority to home visits." The average number of HIV self-test kits distributed per primary contact is an indirect indicator of secondary distribution. In Côte d'Ivoire, the closures of bars and the curfew led to a drop in social contacts, in particular for MSM, and a decrease in the number of clients for female sex workers, resulting in a decline in the average number of kits distributed per contact. When the curfew was lifted in May 2020, a return to the pre-COVID level was observed among MSM, whereas a much lower recovery was observed for female sex workers. In Mali, the curfew at the end of March 2020, which was extended until May, led to a drop of the number of kits distributed per contact. However, there was a recovery and an increase from May onwards. In Senegal, activities restarted in June, with a significant setback compared to the pre-COVID period. Despite a gradual recovery, the average number of HIV self-test kits distributed per contact had not yet reached its pre-crisis level by the end of 2020. Before the COVID-19 crisis, peer educators proposed both conventional rapid HIV testing and HIV self-testing. In March-April, the lack of personal protective equipment, in particular face masks and hydroalcoholic gels, made the application of hygiene measures difficult. Physical distancing was favored during activities. Due to the challenge of safely performing rapid testing in such a context, some peer educators proposed assisted HIV self-test as a replacement for rapid testing. This MSM peer educator in Côte d'Ivoire told us, since March, when we were talking about distancing, it was a bit difficult even to do the classic tests. We took a lot of advantage of the self-test because at least you can offer them. This MSM peer educator from Mali, our work doesn't allow us to respect safety measures. It's a bit difficult. Most of my screening is done for self-testing. I give it to you and I explain it to you, and so you do your test. Even if it's assisted, you do it, and when you are done doing it. Clearly, HIV self-testing has been a tool to maintain access to HIV testing during the crisis. As it was expressed by peer educators working with people who use drugs, HIV self-testing helped to maintain the link during the crisis. In summary, peer educators and key populations have been adaptive and resilient in deploying strategies to ensure continuity of distribution activities while integrating health constraints. These adaptations made it possible to maintain access to HIV testing while respecting the barrier measures. HIV self-testing delivery is flexible enough to adapt to different contexts, in particular in this crisis. You can find more details about the different analyses in a paper published in Frontiers in Public Health and written by Asim Krakwasi and colleagues. Also, the Atlas project developed a document with a summary of the lessons learned during the crisis, available on the Atlas website. Thank you very much for your attention. I would like to thank all Atlas partners, and in particular implementing partners in Côte d'Ivoire, Mali, and Senegal, who have been doing so much to maintain activities during pandemic crisis. Thank you.
Thank you very much, Dr. Lamaranche. I think your presentation is very interesting. It shows quite clearly how COVID pandemic disrupted testing services and your innovative way of addressing that by employing the use of self-testing kits in your program. Thanks very much. I will now turn to the next presenter, who is Dr. Kingston Emmanuel. Dr. Emmanuel, who is our second speaker for this session, is a clinical laboratory manager, Office of HIV and TB of the USAID in Nigeria. He's a public health specialist and a logistics and supply chain management specialist with several years of experience in clinical and academic laboratory practice. He's been involved in the design and implementation of quality assurance, monitoring and evaluation of HIV and AIDS, malaria, hepatitis, and TB prevention, care, and treatment programs, and strengthening national laboratory practice and systems. He is the Clinical Laboratory Program Manager for the USAID in Nigeria, where he provides management oversight to implementing partners in HIV, TB, and malaria, and of course, COVID-19 laboratory programs and support to government on laboratory practice and system strengthening, among others. He will be presenting on the topic Rapid Diagnostics and Advanced HIV, Recent Advances and Successes. Dr. Omo Emmanuel, you have the floor. Your presentation is for 10 minutes.
All right. Hello, everyone. My name is Kingston Emmanuel. I am the Clinical Laboratory Manager for USAID in Nigeria. I will be presenting on rapid diagnostics and advanced HIV, recent advances and successes in Nigeria. I would like to start by giving an overview of rapid diagnostics. They are lateral flow immunochromatographic tests used to detect certain infections in humans. They are generally described as point-of-care tests, POCs. RDTs are advantageous because they are relatively short performance times. That means they have low or reduced turnaround time. Also, they yield results that affect clinical decision-making and allow management decisions to be made during the same encounter with a client. And they also facilitate task shifting to lay cadres in the healthcare delivery continuum. And because it can be conducted or done by lay cadres, it expands access at community settings, peripheral sites, and even primary healthcare facilities. Another advantage of RDTs is that they are less expensive when compared to laboratory-based testing. So let's look at advanced HIV disease now. According to the 2016 consolidated ARV guidelines by the World Health Organization, WHO, any adult or adolescent or child above 5 years with a CD4 count of less than 200 cells per millimeter cube, or is at stage 3 or 4 event at presentation for healthcare care is said to have AHD. Also, because children living with HIV below 5 years of age have a heightened risk of disease progression and mortality regardless of their clinical and immune condition. So therefore, they are said to have advanced HIV disease without need for a CD4 test. The definition we have given above includes those who are ART naive and those who return to care after treatment interruption, as well as those with unsuppressed viral load results. Moving forward, those with AHD have high risk of mortality and morbidity from opportunistic infections, even after they have started antiretroviral treatment. And this risk increases with decreasing CD4 cell count. The common causes of death among people living with HIV and of course those with AHD are TB, severe bacterial infections, and cryptococcal meningitis. However, cryptococcal meningitis is less common in children. I will say why this is important when we come to the diagnosis of advanced HIV disease. So let's look at the diagnosis of advanced HIV disease. Following the diagnosis of advanced HIV disease, those who are diagnosed to have AHD are further screened to rule out opportunistic infections. And those screenings include the use of urine lateral flow assay for TB diagnosis. And this is done for both adults and adolescents, as well as children that are less than 10 years of age. Also, those who test positive with urine lateral flow have their sputum samples sent to a gene expert site to rule out RIF resistance among such clients. The other test that is done as part of the screening of those with AHD is the cryptococcal antigen screening. However, this is not done for children less than 10 years because cryptococcal meningitis is not common among children. And of these three screening tests, you can see that rapid diagnostic test is used for two out of the three. Having talked about RDTs and diagnosis of AHD, we'd like to look at the guidance from PEPFAR concerning the use of CD4 and the diagnosis of AHD. The recommendation is that CD4 testing should be supported in select settings to identify individuals with advanced AHD, HIV disease AHD. It is recommended that it should not be used for determining the eligibility for ART or monitoring response to treatment. And the recommendation further states that when CD4 testing is not available, clinical criteria defined by the WHO should be used to assess for severe illnesses. And of course, those individuals 5 years and older who have persistent documented viremia should have their CD4 also performed. So these are some of the guidance from PEPFAR, but we'll just leave the others that's available on PEPFAR website. So AHD implementation in Nigeria was faced with a demonstration phase that was done in 28 healthcare facilities across four states of Nigeria. The states include Lagos, Rivers, Akwa Ibom, and Anambra State. The lessons that were learned from these four states or 28 healthcare facilities is now being applied or used to scale up AHD implementation across the country, starting from December or last quarter of the year 2021. So what are the successes that we have recorded in Nigeria following implementation of AHD? With the help of RDTs that we're using for AHD screening, and of course for AHD diagnosis and of course for screening of those with AHD, we have found significant increase in access to CD4 tests, with 83% of patients enrolled having CD4 tests done at baseline. And over 50% of these tests was conducted using VisiTech rapid test, one of the rapid diagnostic tests used for AHD diagnosis. We've seen same-day CD4 tests on most of our clients who were tested, meaning that there's an improved turnaround time for CD4 testing. RDT has also ensured that serum CRAG was conducted for over 91% of those identified AHD cases using sample collected at enrollment after they were identified. TB-LF test was conducted for over 82% of AHD patients identified. In fact, testing increased for 56% early in the year to over 80% as at the end of 2021. And this resulted in prompt treatment of those with TB and or those with cryptococcal meningitis, leading to rapid ART initiation for all AHD patients that were identified. So in conclusion, we'd like to say or report that RDTs have helped our program to decentralize CD4, TB, and CRAD testing, making it easier to identify HIV clients with AHD, and of course, with a reduction in cost of testing. RODTs also ensured AHD diagnosis despite the COVID-19 pandemic, and of course, the lockdown that came as a result of the pandemic. In addition, AHD implementation has improved the quality of care for people living with HIV in Nigeria. I would like to acknowledge the following organizations for the work that we have reported in this presentation. And on that note, I'll say thank you for listening.
Thank you very much, Dr. Kingston, for the insightful presentation. We learned quite a lot about advanced HIV diagnosis and how it has helped to achieve some significant successes in not only diagnosing people living with HIV, but also TB and other co-infections. So thank you very much. We will now start with the first session of the questions and answers of this session. This is the first one. When we do the panel discussion, there will be a second Q&A. And so we will now take the questions from the audience. Audience, please know that we would like to take as many questions from you. And so make your questions available. The first one goes to Dr. Lamaranche. And the question is, Dr. Lamaranche, are you seeing or hearing of prevention or risk management measures being put in place to prevent sheer drops or complete absence of data going forward in the countries you presented on? As we know, a lot of community-based adaptations have been put in place. Dr. Lamaranche.
Yes, sorry, can you repeat the questions? I'm not sure I properly understood it at the beginning.
Yes, it reads, Dr. Lamaranche, are you seeing or hearing of prevention or risk management measures being put in place to prevent sheer drops or complete absence of data going forward in the countries you presented on? As we know, a lot of the community-based adaptations have been put in place.
Okay. I'm not sure if the question is about linkage to prevention or if the question is about the type of measures the person was referring to. In my presentation, I was really focused about what happened during the COVID-19 crisis. Sorry, I don't understand the question.
Okay, it's not also clear to me, actually. I thought, okay, so going through the chat, I cannot see any questions. So you may want to answer this question from me, Dr. Lamaranche. Looking at the work you've done, especially during the COVID period, what were the key challenges that you encountered apart from the disruptions? Since you worked with key affected populations, and how did you address those challenges?
I guess the main challenges for all peer educators and professionals on the field during the COVID-19 crisis has been to keep a link with the different populations and to manage the different measures that were put in place. So I've explained there were some adaptations, some like trying to reorganize the activities during daylights instead of nights, trying to do things with small groups because it was not possible to have big groups activities. But one of the other challenges was really about providing prevention equipment, because we have to manage to get some face masks and gels, hydroalcoholic gels. But the thing is, very often the population we were speaking to didn't have a face mask. So a lot of peer educators explained they had to share part of their equipment with the populations because, and so the first weeks really in March, April has been to rethink and to discuss how to integrate COVID-19 measures within the activities, but also to do a lot of explanations to the populations because it was a moment of time where the appropriate things to do were unclear because a lot of population were exposed to discourse from the national government as well, but also coming from Europe and from US. So I guess the big challenge has been really to clarify what was the real danger of COVID-19 and how to perform things. Another thing also is that it was very difficult to do classic rapid testing because in the activities where we were, most peer educators were providing both conventional testing with rapid test and self-testing. And the thing is for rapid test, how to manage to do a rapid test and to keep social distancing with the population. And this is why a lot of peer educators starting to do assisted HIV self-testing instead of conventional rapid tests, because it was a way to preserve social distancing. And really, I guess there has been really that period of 1 month where the proper way to do things were quite fuzzy because it was unclear what was the appropriate things to do because we had different discourse and different speech in the media about how dangerous was COVID.
Okay, so thank you very much. Could you also share with us those who use the self-testing kits and their results were reactive? Could you share with us how you link them up to care or treatment in health facilities and what their response were? Were there any challenges with that?
The first thing very important to know is that within Atlas, we decided to preserve the anonymity that is provided by HIV self-testing. And what we have seen on the field is that people that they like with HIV self-testing is that they can decide when, where, and how to do the test, and if they want to share their test or not. So the first thing is a lot of people on the field, of contacts, for example, sex workers or MSM, do the test on their own and do not share the result with peer educators because they want to keep privacy and because they are afraid that that there could be any breach in terms that it will be known they are HIV positive. So a lot of them are linking to confirmatory testing or to care in other places. So we can not always track what is happening. However, we have been organizing an anonymous phone survey among HIV self-test users, allowing us to document what's happening. What we see is that, first of all, because we implemented secondary distribution, we are not touching only MSM and female sex workers or drug users. We have also a lot of final users of HIV self-test who are clients, partners of female sex workers, female partners of MSM. Overall, people will link to care, to confirmatory testing. Half of them are linking to general public health services. They are not going to dedicated services for MSM or female sex workers because we are reaching this hidden part of these populations. And linkage was probably around 50% to 60%. However, among people who linked to confirmatory testing and who were confirmed HIV positive, all people surveyed were initiated treatments. We have also other feedbacks on the field because even if we are not tracking systematically, people can still call a national hotline to have more information, or some of them decide for their own to recall peer educators. And what we have seen is that among people we contacted peer educators for follow-up, among them we have very high level of confirmatory testing and a very high level of linkage to care.
Okay, thank you. Finally, before I go to Dr. The second presenter, do you, based on the experience, share with us your recommendations in terms of best practices that can be replicated in other countries?
So it will be much more, not only what happens during the COVID-19, but the overall Atlas project. What we see and what is very important has been in that project, that every activities were integrated within pre-existing activities. We didn't develop new HIV self-testing distribution strategies. We integrated HIV self-testing within all the existing activities performed by NGOs or in public health services. And clearly, I guess, it takes more time at the beginning, and the activities starting probably, it takes more time to scale up what we have been doing. But at the end, the result is much more important, and it's easier to move forward with new funding strategy from PEPFAR, from World Fund. So really the integration of HIV self-testing, not as a separate activities, but within the other activities performed by peer educators or by healthcare providers, is really a key element for success.
Okay, thank you. Dr. Omo Emmanuel, one of the audience would like to know from you whether you could share with the audience the best practices in the successes you chalked with advanced HIV care. Dr. Omo Emmanuel, can you hear me? The technical team, could you help us to get Dr. Omo Emmanuel on the line, please? Hello. Okay then, Dr. Lamaranche, I think we can still benefit from your experience if there is any other thing you want to share with us.
Well, I would say another key of success what we have with class, and that we have been presenting in other webinars, is really the idea of secondary distribution. A key component that we have been doing has been to, so you give HIV self-test kits to people, not only for themselves, but to ask them to redistribute to their partners and to their relatives. And clearly, it allowed us to reach people who are usually unreached by conventional strategy, to reach clients of female sex workers, to reach female partners of MSM. And all these peripheral populations are very, very vulnerable. We are currently doing some modeling work to really show how they contribute to the dynamic of the epidemic. And so clearly this idea that, okay, you give tests and then tests will be redistributed to other people to reach new population, it's really something new. It's a new paradigm. It's working as long as you do not track systematically people. Otherwise you create, a client doesn't want to give his phone numbers to be recalled by a peer educator. So we have to accept that, but in the same way that for condom, we are distributing condoms, we're not tracking the condom. And we show in Atlas that, and we're working with WHO at other way to measure the impact. And we are able using programmatic data to show that even if we don't know the result of each HIV self-test use or results, overall, we have been improving access to testing, We have been increasing the number of new diagnoses, and we are improving access to treatment. So we need to think that social network-based strategies are really important. It's authorized by HIV self-testing, and it's a way to have a complementary approach compared to traditional testing.
Thank you very much. I think we have exceeded the time for the first segment of this session.
Thank you.
So we will move to the second segment. I would like to thank you once again, Dr. Lamaranche and Dr. Emmanuel. Please stay with us because there are more questions. So during the Q&A session, Q&A time of the panel discussions, we may want to revisit those questions. So please stay with us. We will now want to start the discussion, the panel discussion. And so I would like to introduce the panel members. So we have the first panel member who will talk to us is Dr. Akudo Igwezu. She is the program manager of the AIDS and STI program of Nigeria, which is under the Ministry of Health, the Federal Ministry of Health of Nigeria. She is a public health specialist and has long experience in health policy, program development, and strategic planning. She has had direct responsibility for designing and deploying public health programs, including those for HIV and AIDS, maternal, newborn, and child health at different levels of the health system in Nigeria. She also has provided leadership for designing and implementing innovative approaches for scaling up access to HIV prevention, treatment, and care services. She currently leads the National HIV and STI Control Program, as I indicated earlier on. The other panel member is Mr. Walter Ndugwe Igwocha. Forgive me if I'm not able to pronounce your name properly. He is the Executive Secretary of Civil Society for HIV and AIDS in Nigeria. He is a public health specialist and administrator and a board member of the National Agency for the Control of AIDS, NACA for short, and he represents the civil society on the board of NACA in Nigeria. He has over 10 years extensive experience in Nigerian HIV and AIDS programming, and especially treatment, care, and support programming. He's been involved in resource mobilization and health financing, prevention and organizational capacity strengthening, and networking development for non-governmental organizations and also community-based organizations in Nigeria. And the third panel member is Professor William Ampofu, who is currently the chair of the African Vaccine Manufacturing Initiative. He's a senior editor for the African Journal for Laboratory Medicine and ambassador for Ghana, Journal of African Society for Laboratory Medicine. He has conducted temporary assignments throughout Africa on behalf of the World Health Organization, Commonwealth Secretariat Health Division, U.S. Department of Defense, German International Development Agency, and the USAID. And last but not the least, we have Manasan Rubani, who will be our fourth panel member. And he is the National Laboratory Technical Working Group and CEO of PEEP Medical Laboratory Services. He has been involved in HIV diagnosis at both national and international levels. Ladies and gentlemen, if you are here, could you confirm by indicating that yes? Hello?
Yes, I'm here.
Okay.
Yes, we're here. Thank you for the
I'm here too.
All right. How about Madam? Okay, she's not here. So my first question goes to Walter. Walter, from the discussions, you know that self-testing has become available and it's helping in reaching out to underserved populations, like key affected populations and others. When they test, they have to be linked with health facilities for further diagnosis and treatment. Being a civil society person, the simple question to you is to share from your perspective, what are some of the community engagement strategies that can be adopted by countries to ensure that we increase uptake of self-testing, and also there is provision to assure confidentiality and retention in care for people who are diagnosed. Thank you. You have 5 minutes, please.
Okay, thank you so much, Atwine. Exactly, I'll just share a few thoughts from this end. When the COVID pandemic broke out, and there were lockdowns all over the place, it posed a great challenge to everyone. And that great challenge, Nigeria was not excluded from it. And that great challenge is, how do we make sure that we get HIV self-testing kits to members in the community, to key affected population, and to all the underserved population who originally might not even be aware about what HIV testing was. So the first thing we did at the national level, we did mobilize a community, sort of a community panel discussion that ran for 21 good weeks, talking about creating awareness about HIV self-testing in the first place. After that, within those 21 weeks, we moved in mass to communities where the underserved population, pregnant women, and we moved the mass, and we made sure that we rightfully provided information about HIV self-testing and the advantage it added to the national data. And what happened was that we looked into the research and into the data and studies that previously have been done in country. And our interest was, how do we integrate community members? How do we make sure that we create the linkage and integration from someone who's gone to his house to test and make sure that the person comes back to facility for follow-up or for retesting or for confirmatory test. And we looked at the 4 models that were done by one university in the United States in collaboration with NIMA, Nigeria Institute of Medical medical research. And we found out that some of the approaches that they recommended in the research study could be helpful. One was the use of mobile technology for where it is possible. And two was the use of drop-in centers integrated to the OSS centers for members of key affected population in the OS centers that they do have. And of course, the use of mentor mothers that for pregnant women who originally have issues with coming to facilities and integrating the mentor mothers with the traditional birth attendants. So with these three studies that we saw, what we then did was that we piloted and implemented different strategies according to the different geographical space that we have in Nigeria. And I must say at this point in time, one of the key things that we saw that yielded results that we needed was the fact that the mentor mothers strategy, where we just distributed HIV self-testing kits to mentor mothers and have them to redistribute them to pregnant women in their communities, helped us to have the mothers coming back, have the pregnant women coming back to the mentor mothers to come and say, the test kit you gave to me, actually, I saw 2 lines. What does these 2 lines mean? And okay, come to the facility, let's have a retest and let's follow it up there. On the other side, for the young people, the fact that when they went back home and tested and they were able to come back, they were able to send a text message to a particular number and have the number to call them up willingly. We saw that also yielded results for the young people or for the adolescents and for the key population. We found out that them using the OSS centers and having the OSS center distribute to HIV test kits were very, very particularly helpful. So when we placed the HIV self-testing kits through the various implementing partners in the country, because it was quite a huge national event program or activity, it helped them to come back to the OSS center. Some of them just went out of the OSS centers and there and then did their HIV self-testing and came back to say, please, I need a confirmatory result. Some of them also took some for their partners, took some for their partners and their friends and all of that. And that helped to create a lot of gaps. And we were not measuring the immediate result it will yield to us, but what we were interested in is knowing the overall result it will yield in our national data when we come to look at the overall data for Nigeria in terms of those tested and those placed on treatment. And what we found out at the end of, by the end of the year was the fact that Nigeria was able to meet its own target in terms of testing. Nigeria was able to meet its own target in terms of those who are interested, or those who should be on treatment, and those who should be tested, and those who should know their status by the end of the year, irrespective of all the challenges and all the lockdown we had, because we were able to mobilize community members from those who live with HIV, from civil society, from community-based organizations, to just go to the communities and use these 3 strategies to drop it across community members' homes and have them to either use any of the 3 strategies they like most to be able to report what they have done.
Walter, thank you very much. Your presentation has been quite interesting. We've learned how you applied research to develop strategies for your program. And we are happy that Nigeria was able to meet its testing targets. That is quite exceptional. So thanks very much. The next discussant is Professor Ampofu. Please, my question to you is that in fact, before I ask the question, I need to indicate that, as you are aware, there are many rapid diagnostic tests on the market, especially for self-testing. And manufacturers usually use various tactics to push their products in our part of the world. And so what would you share with us, Western Central African countries? What measures should be adopted by countries in the sub-region to assure quality and cost efficiency of HIV self-testing kits? Thank you, Prof. You have 5 minutes.
Yeah, thank you. Thank you for the question. I think that this can be answered using our own situation in Ghana, where in line with global recommendations, we have examined the potential of the adoption of HIV self-testing. So we looked at our national capacity, our national situation, and we adopted a simple approach where HIV self-test kits that had been pre-qualified by WHO was the first resource that we looked at. Kits that have met, global standards, for use. And then we checked with our national regulator, Food and Drugs Authority, to see if any of these commercially available kits that WHO had pre-qualified were available in country. So that was the starting point. So we developed a simple protocol to assess these available FDA Ghana registered WHO pre-qualified HIV self-test kits. We use the same approach for assessment of rapid diagnostic tests for HIV testing. We set up panels of blood samples that had been fully characterized for the presence or absence of antibodies against HIV 1 and 2. And we looked at the sensitivity and the specificity of these test kits. We found there were 4 RDTs that had been registered in Ghana's FDA. And when we did the assessment with the panel of characterized blood samples in the laboratory, the results gave us suitable or acceptable results for 3 out of the 4 already registered test kits. So we avoided any pressure from any would-be or potential, supplier who was not registered already with the FDA. And then we set out to do a lay users assessment. We were thinking that we could make these RDTs for HIV self-testing available in pharmacy and commercial retail shops where already malaria RDTs are available for sale and purchase by the general public. So we had a consultative session with the pharmacy group, and then we set up a small pilot study to look at usability of these RDTs, the 3 that had passed our standards, to see how lay users understood the use of these kits as explained by the manufacturer. We got feedback from these lay users. And then we sat down and analyzed and tried to come up with a tool that would enable us to collect data from centers that would make this self-test available, and also to provide a channel for counselors who could be contacted by people who were procuring these HIV self-test kits and use them. So our target is to roll this out in a couple of regions in Ghana, and having found suitable test kits, having done training for pharmacy staff, and having seen how lay users have responded, we have a very good idea of what these commercially available RDTs are. So the final step that we are doing currently is to the commercial, the suppliers have made these test kits available on a pilot basis, and we are looking at what is the acceptability, the affordability data that we will get from the reaction of clients who will buy these self-test kits. We will then be able to understand what is the acceptable price, and then we will then set up, a data system to support would-be users of this. So this is one approach that we have tried in Ghana, and this is something that I would like to recommend to the community in West Africa. These self-test kits come with very suitable explanatory brochures. Everything is contained in a self-test kit. They seem to be quite user-friendly. One of the self-test kits is actually non-invasive. It's a mouth swab. And I think in the event of COVID, the general public has become more used to the fact of having swabs in the oral cavity. So these are the experiences that we have to share from Ghana. And I think that we can use this to provide scientific data. And then it's also the last part I just talked about is where the commercial supplier, actually does a field survey to see what price would be acceptable to the public, thereby, making it what you call it, a client's market, understanding what the clients can pay for. Yes. So thank you very much. This is what we have done in Ghana. We think this is a suitable model. It's a pilot that others can also try and adapt and modify for their own setting. Over.
Thank you very much, Prof, for that succinct presentation. Now we will go to the next panel member, who is Manison Ubainu. Please forgive me if I'm not pronouncing your name properly. And my question to you, sir, is that community-based differentiated services, HIV differentiated testing services is an effective way of, increasing uptake of testing in our part of the world. And so individuals who are diagnosed at the community level are often referred to health facilities for further diagnosis and treatment. Could you share with us, sir, what you would suggest as best practices in clinical management of such clients, focusing on the continuum of care? We want to see the full extent of care continuum in your perspective. Thank you very much.
Thank you very much. Differential testing has really drastically improved the testing services, and it is very, very important that people who are testing positive from such activities are adequately and properly referred for clinical management, for clinical care. Just as we said, differential care means you have different ways of getting people to get tested. In Nigeria, a lot of programs have been in place, and this has really made it possible to access testing in especially rural areas, and to visit people who normally wouldn't want to show that they are testing, they are coming out to test for HIV. Now, the program in Nigeria, wherever testing is done, there's always an arrangement to refer positive results for care. Now, the challenge is, just as some people don't want to come openly to do testing, when they test positive and you send them to clinical care, some of them also find it difficult to just appear in the facilities. And therefore, in Nigeria, it's not only differential testing, even the care has now been differentiated, and efforts are being made to make sure that people can access care and be monitored and continuously attend their clinics and collect their drugs and have their monitoring tests done. Now, I won't waste too much time on the clinical care, but what is done in Nigeria now is that Walter knows very well, there are so many areas where people who have tested positive and have met with their clinicians can access even drugs. People are now using community pharmacies, groups in hard to reach areas so that you can get your drug as close as possible to where you are. That will limit exposure, and it will also limit expenses. But there is always a situation where you must also go to your clinician so that you can be reviewed. One of the most difficult things is the main test that is used to monitor people under care is viral load. And of course, we had earlier advanced HIV disease. When you are in treatment, you have to be checked. Apart from the people who are under 5, once you are positive, whether your CD4 is below 200 or not, it is advanced HIV. But those who are adults and are receiving treatment, you have to once in a while check their CD4 to see whether they can be classified as people with AHT. This is one of the areas where point of care becomes very important. The unfortunate thing up till now is that most point of care for viral load are not rapid, and they still require a lot of infrastructure. The best one that I have dealt with is MPMA, which you can carry to the field. You can go anywhere with it, and a viral load can be done for you to monitor your response to therapy. Or, yes. Now, but even that one is not a rapid test. It takes more than slightly above 1 hour to complete a test. So if a normal working day for a physician in his clinic is 8 hours, it means he can virtually do only 6 patients in a day, the viral load. So there's a lot of things that needs to be done to improve on that area, because it is essential that we also, apart from just differential testing, we also encourage systems, facilities that will encourage differential monitoring as well, so that wherever you are, as close as possible, you can monitor your viral load. And what I would recommend is to especially manufacturers, we have what we call fluorescent meters nowadays that are being used for so many things, for endocrinology, for all sort of sophisticated investigation. We should quickly begin to adopt this to molecular systems that can make it possible to go out on the field and meet these people, just as we met them in differential testing, that they could regularly get tested in terms of monitoring the care they are receiving. If we don't do that, you have a lot of people who fall out. Some of them, the facility that they can get this testing is so far, they cannot afford to travel to those places. And many other, if you come here, sometimes during the rainy season, your village, it rains, you cannot move to where your clinic is, simply because there's no bridge across a river that is now flooded. And there are so many obstacles. Therefore, there is a need to continuously begin to look at technologies that are adaptable in monitoring, just like CD4 now has a rapid test, which is very good, and you can use it to differentiate effectiveness of care. We need to look at some of the tests that is required in terms of monitoring, so that people can continuously get monitored and be told, oh, your treatment is going well, if there is a test that encourages you to know that what you are doing is good, it encourages you to comply, to continue testing, and it encourages continuum of care. We need to do those kind of things, but meeting them where they are is very essential. And Nigeria has a very nice principle on that, so that they get their drugs regularly. So we should add within that system so that they can also get tested for purposes of care. I think this is very, very an expensive thing, but the scientific community, those doing research, developing test systems, should simplify so that we can improve.
Sorry, sir, I don't mean to cut you, but yes, if you can wind up now, because you've exceeded the time.
Yes, that I've just winded up that statement that we need to improve on making certain test systems available, just as diagnostic devices are now available and utilized in differential testing.
Okay, thank you very much, sir. Once again, I want to thank the panel members for the insightful presentation. We have quite a number of questions, and so we will want to answer as many as possible. We have some in French. Unfortunately, I don't speak French, so if the technical team could assist in asking that. Hello?
I could speak French if necessary.
Yes. Yes, but so if you have access to the questions, then you may want to answer that question. But first, I would want to the first question is how to focus on identifying and testing people who are unaware of their HIV infection and diagnosing people earlier in the course of their infection. How to place the key population at the center of testing strategy. So that's number one. I would like to ask Walter to assist with this question. Hello, Walter, are you there? Okay. Whilst we are trying to get Walter on the line, Dr. Lamaranche, I know you are.
I am here. You were asking me something.
Yes. There is a question here. It says, how do you focus on identifying and testing people who are unaware of their HIV infection and diagnosing people earlier in the course of their infection? How to place the key population at the center of HIV testing strategy?
So one key thing we did in the course of the COVID, we accelerated HIV information and education so much. We thank again the Nigerian government and the various radio stations and all of that. So we first of all scaled up the information available to community members and those in hard to reach areas about HIV and HIV information and HIV self-testing. The next we did was with members of the community of the key populations. We held a separate symposia or separate community discussions with them virtually, and also within the community, within those that could move to their houses, about HIV, the gains of HIV self-testing and how it could be a game changer in the event. So in terms of the integration and in the linkages now, we collaborated with implementing partners to say this. We have already done an extensive HIV research in Nigeria, which shows exactly where we need to focus in terms of HIV prevalence in Nigeria and where it occurs most. So what we all did was to use those geographical mappings and the members of the key population to actually focus our intervention in those areas, and that's what has helped us to actually achieve 97. Nigeria is on 97, 97, and 96 now. And I do agree with the last speaker. One thing we identified that we have actually needed to add to the to our diagnostics in Nigeria is the last viral load testing. Now, that is what our focus is on now, to ask the implementing partners to actually come up to scale with respect to community diagnosis, community testing for viral load. It has to happen and it needs to happen.
Thank you. Okay. Okay. So, yes, Dr. Lamaranche, you can also make your point.
Just to add a quick comment, and I'm thinking in particular about a brief consideration was published a year ago by UNAIDS, but it was in the middle of COVID. So a lot of people didn't think about it, about universal test and connect approaches. One of the things is very often we have been trying to target and to identify specific populations. But on the field, you have some people who do not recognize as MSM or as sex workers. And if you want to target clients, well, they will not serve our clients. So a good way to change our way to implement things is to think in terms of geographical targeting. We know there are places with sex work. I do not need to be sure that the girl working there is a sex worker. She is in that place. It's enough to propose HIV testing. We have guys coming there. Maybe some of them are not clients of sex workers. Not a problem. Intervene them. So we have probably a way to change the paradigm, to think where are the places we need to test people, even if we are not sure that all of them are part of the key populations. No, just implement. If we implement things in a way where we document things properly, we will know the positivity rate of the different type of activities and learn from that, and know that this type of place is more relevant than other type of places. But we have to switch things because the core part of key populations who are self-identifying as a key population members, those persons usually, we are very good NGOs working with them. We are very good peer educators, and we are able to reach this population. Now, all these hidden parts and the partners of these populations are much more difficult to reach. And we need to change the focus to not be sure if the person is relevant, but to think where to test rather than who to test.
Yeah.
All right. Thank you. I have a number of questions for Dr. Emmanuel. I don't know if he's still with us. Okay, I hope someone will be able to help. If any of you on the panel, maybe Prof. Ampofu and others, you could assist. But there is one general question, and I think that question goes to Walter.
Yeah.
It says, what are some of the challenges did you encounter with self-testing of HIV in Nigeria? As you rightly said, HIV testing kits were distributed through mentor mothers, youth, and among the key population, and they bring feedback of test results. Can you elaborate on that, please?
Thank you for this question. The greatest or the very big challenge we did face with, propagating HIV self-testing in Nigeria was the religious leaders. So the religious leaders had this unwritten rule, unwritten policy that everyone that wants to get married must bring HIV test results, whether they like it or they don't like it. So for the religious leaders, both faith, whether Christian or Muslim, were the major challenges we had. How do we convince them to accept HIV self-testing and probably place it at the doorstep of their church entrance or their mosque entrance, and at the end of the service, and have someone to pick it up and get themselves tested, and have a number to call and to follow up? So this was the major challenge we did face with the religious. But what we went about it was the fact that we actually brought in the religious leaders, the leaders of the Christian Association of Nigeria, the multi-faith agency, and we had to go to the Sultan in Sokoto and had to say, you do this test yourself and demonstrate to all the faithfuls that actually there are no inclinations about this test, and we have to, make this to be open to everyone. And what did that help us to do? Just like Joseph was trying to say, Lamaranche was trying to say, what it helped us to do was that it brought a little bit of twist to the geographical mapping that we had already done regarding the HIV testing and HIV prevalence in Nigeria. There were local governments, we actually were thinking that there were no people in those local governments that were, the positivity yield would be very low. By the time we stratified and by the time we did a massive campaign and distributed HIV test kits to everyone, self-testing kits to everyone, we saw that those local governments and areas we were downplaying and looking down on actually surpassed some other local governments we had actually hoped to have some high yield. So that brought an interesting conversation, and that's what I think that contributed to the UNH document that eventually released, to say those places we are not looking, they actually could be plausible yields we have in these places we're not looking, because they are still within the same strata, the same local government, the same states that are actually having high prevalence in the rate. So first was the conversation and the challenge with the religious leader. Another major challenge we had was the fact that people were already tired about hearing HIV and AIDS related. So bringing the conversation about HIV self-testing was, we've had this HIV for the past 20 years, we're tired about it. So there were a lot of challenge attitude about community members. But what we did differently was to integrate it again in the conversation around condom. If you could buy a condom, you could actually get yourself a HIV self-testing kit. And that helped, to put the message forward and to push the message to the community members. And they were, since they already know about condom, having the knowledge. And one of the things that they kept, having the myths about HIV self-testing kit was the fact that all they have known all their life, HIV self-testing has been through blood. So now, if you're going to tell them a message about HIV self-testing that has to do with saliva, they absolutely had difficulties believing it. But when eventually they used it, they themselves found out it was very much better and it was easier to use.
Okay, thank you very much. Dr. Omo Emmanuel doesn't seem to be with us. So, Dr. Manason, could you help us answer this question, which was supposed to have been answered by him? The RDT for CD4 is useful for advanced HIV diagnosis, but do you think that it could be generalized for all PLHIV? In Nigeria, is the RDT for CD4 used to monitor other groups of patients? For example, those offering HIV drug resistance testing.
Well, the kit for the CD4 testing, VCTEC, I happen to be the chairman who validated that device for use in Nigeria. The main function of that is to tell you the CD4 count in any patient. So, and the definition of advanced HIV disease, the first time we validated that the device detects a CD4 of 350. So they now had to go back and do again, because it is now going to be used to define what we are interested in: people who are CD4 below 200 or above 200. Now, apart from diagnosing advanced HIV disease, the value of this kit is that anybody who is on treatment, and suppose treatment is failing, when treatment is failing, it means your CD4 count goes down. So if you do that test and your CD4 count is above 200, next time when you come, it has now gone below 200. It means your treatment is no more effective. So, and the test can be done on anybody. What is not useful generally is if you have people who have started treatment and their CD4 count is very high, you will just be wasting your time doing that because it will just be showing you above 200, above 200. So the criticality of this is the diagnosis of advanced HIV disease. But the test can be done on anybody. If you are just tested positive, it can be used on you to know, especially if you have symptoms that tend to show that you are immunocompromised, it can be done. But even people who have been on treatment for quite a long time, and there are evidence that they are beginning to show signs of treatment failure, you can use the rapid test kit for VisiTech. And you will now, because the thing is you've been on treatment, and once you discover that you have developed AHD, it means you are now going to undergo a lot of investigations. We begin to look for opportunistic infection because your management now means deliberately there's going to be search for opportunistic infection and treated. So yes, the thing can be used even for people who have been on treatment with HIV, with antiretroviral drugs. That will help to tell you that this person is a failure in terms of response to the ARV treatment, in addition to diagnosing that the person has advanced HIV disease.
Okay, thank you very much, Doc. Yeah, now, the next question is that how did you handle the issue or the challenge with internalized stigma among PLHIV who are on treatment? And to explain that question, the questioner says, are ART patients still hiding their HIV status? Is the question clear? The questioner says that there is a challenge with stigma among people on treatment. And he wants to know how this problem or challenge is being handled in our various countries, especially if you have persons living with HIV who are on treatment still hiding their HIV status.
If you allow me, I don't know. Yes. So if you allow me, I will go ahead to agree completely with the person. Why we have made progress with 95, 95, 95, what we are seeing at the moment shooting up is the conversation or the incidence of stigma. Shooting very, very high. We just finished treating one where a boy in secondary school was kicked out of secondary school because of his HIV status. In 21st century, this should not be happening. So this has also further pushed back those who would have willingly come out within West and Central Africa region to declare their HIV status. It has also pushed them back. But on the overall, we need to be cognizant and recognize the fact that we have the anti-stigma law 100% existed. And in the anti-stigma law, I can quote various articles of the anti-stigma law. It states that a person has the wish and has the right to consent or to declare his status either to anybody, not just publicly or openly. If I have HIV and I do not want to disclose my status to my partner, I have the right to do that, unless in medical emergency where within the medical team have to know it first. So we will have to, first of all, recognize that right as part of the human right and as part of what our law says in that regard. But the conversation of the question about the person asking about, has the HIV treatment or has what has happened in our national response led to high incidences of stigma? The absolute answer it is yes, because the way our national treatment is framed in West and Central Africa at the moment, we're interested in giving everyone who has HIV pills to drink. Just take pills and achieve viral suppression. Whatever that happens to you, socioeconomically and otherwise, you have to deal with it yourself. And we in the civil society think that we will now need to start doing things differently by recognizing the fact that we have to bring back on board the prevention messages and the prevention campaign. And we also have to, commit some significant resources towards addressing issues about stigma, gender and human rights that is coming. And we can, when we measure the partner notification violence index or indicators that we have at the national level, we were all wowed to the extent of violence that has come up by way of disclosure and all of that happened. So a lot of work still needs to be done. And I think as output of this symposium, part of the things that should be going out as next step will be to commit some efforts towards increasing, reducing stigma in the community and increasing messages around human rights and gender activities. Thank you.
Okay, thank you.
The main hard probably to that question is stigma is really a structural and a social issue, and you cannot change with simple activities the perceptions of societies. And at some point, we do not have anymore in the field of HIV national campaigns, as it was presented by Walter. We are not communicating about you equal you, undetectable equal untransmittable. That things change completely the way we can perceive people living with HIV, because people on treatments do not transmit. And there is something recently I was reading some analyses of school books from different countries in West Africa. HIV is presented the same way than 25 years ago. So at some point, if we do not change massively the way we perceive and communicate on HIV and all the news, the thing is, we are always in our community of HIV people, and we are completely forgetting that most people do not know what we know, and we need to have mass campaign about the changes in HIV and for you.
Thank you. My personal question to Prof. Ampofu, there is argument that the non-invasive rapid test kits, like the oral swabs and things, they are second or third generation test kits and are less efficient less efficient than the fourth generation test kits that are blood-based. This is the argument used to push some of the test kits by manufacturers in our part of the world. How could you help us settle this kind of argument so that countries will know what to do? Thank you, Prof.
Yes, Chairman. I think it's the same strategy to evaluate them. If a commercial supplier brings me a test kit and says, his kit is better than the other ones that we carry out an evaluation because the panels are usually composed from recent characterized samples. And so you have a clear idea of the performance of the assay. Now, one thing about the non-invasive kits is that they are able to use both blood and also the material, the oral mucosal transfused that we pick up. So you have an advantage there with the non-invasive kit that it can also test blood, in addition to being able to pick up antibodies in the oral mucosal transfused. I think one thing we can always argue about is the cost, okay? And that if we have devices that perform similarly efficiently, it is the price that we have to negotiate and try and get the most, affordable product that is also efficient. So that is my response. We have seen that with the advent of COVID, we have several RDT, several tests that have come about which were not available at the beginning, which could also now influence other diseases. We could probably be seeing maybe a combined COVID HIV kit soon. We have a combined syphilis HIV kit. So it depends on the commercial, I don't want to say commercial usage, but also the cost effectiveness that the producers will also, benefit from the program. So going forward, there are possibilities that we will be able to see. So, and we will continue to evaluate them as they come on the scene. Yes, fourth generation assays are generally better than third generation assays, but with the non-invasive assays, these are new products. And sometimes it also depends on the condition of the oral cavity, if you're going to be taking an oral mucosal transudate, okay? Whereas with blood, once you have a lancet pricking and you have the blood coming out and you have a buffer, it's a direct detection of the antibodies in there. But in the mouth, you have to think about what the person is eating, what the person has drunk before, if it is urine, what time of the day, what type of, how concentrated the urine is, whether the person drank a lot of alcohol the night before, so sometimes the non-invasive tests do need to be evaluated and checked in real life situations to see how they perform. Over.
Thank you very much, Prof. The last question is a general one, and any of you can answer. It says, there are people who don't want to test. How do we handle them or engage them to get them tested?
The same thing, people don't want to take a vaccine. There'll always be a group of people who have their own personal opinions about these interventions that we continue to roll out. So we just need to continue to engage. We just need to continue to engage and continue to persist, and try and now use social media to also share lay user experiences, that could be more acceptable and believable rather than straight scientific papers published in scientific journals. Now we have to take the evidence to the people. We have to brand it in a way that they will understand and perceive. And these are the challenges that we face going forward.
I just want to share what happened to us when we went into communities in Nigeria. So there were community meets about testing. First was the one of blood. But so what changed the equation about those who didn't want to test was when they saw their community leaders taking up the test and how easy it was to do the oral HIV, rapid HIV self-testing. It changed the game. It encouraged them to do that and to come and test. Second was also the use of the same religious leaders. When the religious leaders, some of them in the communities right there and there during church services or during Muslim Friday prayers actually use this HIV rapid test self-testing kit. It helped to move a lot. And I also finally would say we still have a long way to go with in terms of campaigning and helping people to know. An important message that we've incorporated in HIV self-testing is you equals you. We cannot go back about it, and we have to just keep moving forward, and we have to keep telling everyone until we get everywhere saturated with the message.
Okay, so I will give Dr. Lamaranche and Dr. Manasseh the opportunity for their closing remarks. So, Lamaranche.
Thank you very much. It has been a pleasure to be with you today. And I guess that one of the key messages is that HIV self-testing is feasible, it is acceptable, and that we need to simplify testing in general to allow more people to get access to HIV testing. Thank you.
Thank you. Yes, sir.
Well, a lot of testing activities is going on, but because of the complexity and the high-tech nature of viral load testing, it is actually limiting monitoring for people who are on treatment or being clinically managed the scientific community must do something to begin to make viral load testing a point of care activity. If possible, make it a rapid test. A rapid test simply means you get result in less than 30 minutes. That will do a lot of good in compliance and continuum of management of people with HIV. Thank you.
Yes, thank you very much. That's a very important point, because if truly you equals you, then people must be given the opportunity to have viral load test. And having a much simpler test, not only in terms of procedures, but also the type of equipment used and the rapidity of generating test results will go a long way to improve the service. I would like to thank all of you very much for participating in these discussions, especially our panel members and our two speakers. We also thank you, the cherished audience, and on behalf of APIN Public Health Initiative, we would also like to encourage all participants to participate in subsequent sessions, which you can find the details from the website. We hope that the information shared is useful for your work, especially those of us in West and Central Africa, and we will go back home to replicate what we have learned from the experiences of Nigeria, Ghana, Senegal, Cote d'Ivoire, and Mali. I will want to end here and thank all of you for participating. And please also remember to participate in the evaluation survey at the end of this meeting for the overall symposium. All participants are encouraged to do so, and you will receive an email on Friday requesting that you fill in the survey questions as a way of evaluating this symposium. Please be open and frank about your observations. We would also greatly appreciate your feedback in whatever form you want to send it, whether by email or any other use of any other channel, which will help us to continually improve our symposiums. And please, you can send any feedback to the IAS email address, which is provided for you in this session. You already have it, so please use it. Thank you. And I think if I should read it out. It is IAS in uppercase, capitals, IAS, then edu. Edu is in small case, EDU at iasociety.org, iasociety.org. Thank you very much and enjoy the rest of the day. Bye-bye.